Hello, welcome to our Health Matters webinar, Telling Stories of Life and Medicine in the 11th Hour. I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today. In this webinar, we'll gain insights on health and healthcare in the final chapter of our lives. It's a moment that we all know will arrive, but that our American healthcare system does its best to brush past in a rush for interventions at all costs. We'll talk about the emerging field of palliative care, which even some in the medical profession fail to give its due. We're holding this webinar in Los Angeles, a place shown to be an epicenter of end-of-life overtreatment, according to data from the Dartmouth Atlas. Here to help us understand all this will be two leading experts. Dr. Sunita Puri is the author of That Good Night, Life and Medicine in the 11th Hour, and the Medical Director for Palliative Care at the Keck Medical Center and Norris Cancer Center of the University of Southern California. In conversation with her, we'll hear from Fran Smith, a veteran journalist and co-author of the award-winning book, Changing the Way We Die. This webinar is offered thanks to the generous support of the National Institute for Healthcare Management Foundation and the Commonwealth Fund. You can tweet about the webinar at the hashtag #PalliativeChat. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions in the control panel of GoToWebinar. You can write us if you are experiencing technical problems there as well. We'll be archiving this webinar at centerforhealthjournalism.org. Now let's turn to our speakers. Dr. Puri, early in your book, you write about a moment when you realized that clear and compassionate conversations can be had in a medical setting about living with a serious illness. Might you be able to read an excerpt?
Okay, perfect. So this is an excerpt from the very beginning of the book, a chapter called Shift. And I'm going to read to you about the story of Donna, who was a patient I met at the very, very end of medical school. And she had come to the conclusion that the dialysis she'd been receiving for a long time was not something she wanted to continue. Sunlight poured through the window across from Donna's hospital bed. I noticed her squinting and lowered the shade slightly. Instead of hovering over her or leaning against the wall as we spoke, Dr. McCormick, Ellen, and I, all members of the palliative care team, sat in folding chairs facing Donna. On the table next to her hospital bed, there was a brown tray with plastic rectangles of smashed peas, fluorescent orange carrots, and a small chicken breast. Someone had checked the boxes low sodium and renal diet and diabetic on a pink slip of paper taped to the side of the tray. "It's dialysis food," Donna said, wrinkling her nose as she noticed me looking at her lunch. "Makes me more nauseated than my kidneys do." A copy of Chicken Soup for the Soul, many of its yellowed pages dog-eared, rested next to her untouched tray. Dr. McCormick spoke to Donna in a tone that exuded compassion and presence. "We're from the palliative care team," he said, "and we're just here to get to know you and support you as you think through some of the decisions your medical team is asking you to make." "I need all the support I can get," Donna replied, her voice fading into a whisper as she made her way through her sentences. Donna's fatigue penetrated her every word and action. Lifting a forkful of green beans to her mouth had become an accomplishment, she told us. Dread had consumed her on the ambulance ride from her dialysis center to the hospital. She told us she had felt her heart thumping against her chest as though it were warning her of impending danger. She knew her doctors would offer her another procedure or surgery to fix her fistula and allow her to continue dialysis. But a question surfaced in her mind, one she'd considered from time to time over the past few months. Would a shorter life without dialysis be better than a longer life with dialysis? "I'm not suicidal," she whispered. I'm tired. She told us about the many ways that dialysis had enabled her to enjoy the past 5 years. She would miss her adopted daughter and the view of the Bay Bridge from her front porch. She would miss making her mother's recipes for barbecued ribs and lemon tart, but she wouldn't miss the crushing fatigue of kidney failure that had slowly deprived her of one independence after another. I am sorry this has been so tough for you, Dr. McCormick said to her, handing her a box of tissues. I hear you saying that dialysis has helped you to live well and enjoy your life, but I also hear that over the past year, it's really making you tired, and sometimes it's even made you sick. Yes, it has, Donna said, pausing to catch her breath. Even crying wore her out. Have your other doctors talked with you about what stopping dialysis would mean? I held my breath, unsure exactly what Dr. McCormick was asking. Did he want Donna to say out loud that she knew she would die without dialysis? Honestly, they didn't really tell me too much, she said, wrapping thin shreds of tissue paper around her right index finger. What would happen to me? Well, the first thing you need to know is that it is okay for you to want to stop dialysis if it is not helping you to live well, Dr. McCormick began. But it is also very important for you to understand what would happen without dialysis. The toxins that dialysis usually removes from your blood would build up. And then I would die, Donna whispered. Yes, you would die from your kidneys failing, Dr. McCormick said. I had never seen a doctor tell a patient so directly that they would soon die. I'd seen well-intentioned doctors try to soften the blow of hard facts by cluttering their sentences with rambling apologies or canned reassurances, talking around the truth. Their worry that a patient might be unable to handle plainly stated facts, that they must require unnecessary words as a sort of shock absorber, struck me as a form of paternalism. Dr. McCormick's sentences, concise and compassionate, almost felt transgressive. I had never seen a doctor disclose a wrenching truth with acceptance rather than avoidance. His voice was steady and clear, free of euphemisms like passing on or being at peace. I waited for Donna to stop the conversation, to say that discussing death so openly overwhelmed her. But all she did was nod. It was as though Dr. McCormick had validated what she already knew, as if she found the statement of truth comforting. Our focus, he said, would be making sure that you are comfortable and free of any suffering during that time. He looked Donna in the eyes, placing his hand respectfully on her shoulder and nodding his head deeply to emphasize the last part of that sentence. How would I suffer? Donna asked, suddenly looking at me. Even though after years of studying, I could tell Donna everything about how her kidneys work and what happens to her body when they fail, I hadn't the slightest idea how she would experience dying from kidney failure or what I could do to ease her suffering. My silence stunned me. I struggled to understand how I could be on the cusp of becoming a physician and lack the words to answer her question, to guide her through the one certain transition every patient of mine, every human being, including myself, would experience.
Thank you so much, Dr. Puri. Fran, I'll be interested in your conversation with Dr. Puri on how this moment speaks more broadly of where we are with the medical system today.
Yes, thank you. And that excerpt really gives a beautiful sense of this book, which I was so blown away by how vivid it was, but also what an honest exploration it was of your own process your own struggles, to learn a kind of medicine that you hadn't been trained to do, and to unlearn a kind of medicine that you had spent years training to do. So I hope we can talk about that. And I'm gonna, before we kind of jump right into the heart of the subject, tell me a little bit about what you hope people learn from the book, very, very quickly and simply.
Yeah, so, what I hope people take from the book is a couple things. One, I really wrote it with my writer hat on, and my doctor hat was there too, but I really wanted it to be beautiful storytelling as a way into some very difficult subjects. And I really hope that people take away from it how deeply socialized doctors are to avoid this whole area of life that we will all face, living with serious illness and what that means. And I really hope that people will read the stories and think, if I was this patient, what would I want for myself? What is the sort of language I might take away from this book to have discussions with myself, with people I love, and with my own healthcare providers about what my wishes would be for myself if I got really, really sick. So I wrote it in a writerly way, but I really wrote it to be of service to people. And very selfishly also, I just have to add this in, I wanted to write the book I wish I could have read as a trainee in medicine and as someone with aging parents.
Great. Well, I love the word that is in that excerpt, and I think it appears several times in the book, transgressive. And,
yeah.
And so let's just kind of get a baseline here. We have an audience of journalists, policymakers, people who are steeped in this, and people who may be new to this. So let's just start with some definitions. What is palliative care? What is hospice? What is end-of-life care? Where do these blur? Where do these come together? And where are they distinct?
That's a great question. And these distinctions are things I have to explain every day, even to my colleagues in medicine, to patients and families. So palliative care is a specialized type of medical care that we provide to patients facing a serious illness at any stage. So what we do is we attend to the physical, the emotional, and the spiritual aspects of suffering that come when you're living with, for example, advanced cancer or advanced heart failure. And we do it in a team approach. So I'm a physician on the team, I have a nurse practitioner, and we have a social worker, and we work with our chaplaincy services at the hospital really often, because attending to these many types of suffering really takes a team. And I think of hospice as a type of palliative care that we provide in the last 6 months of life. Palliative care can be provided to patients at any age and at any stage of a disease. So you can have just gotten a diagnosis of cancer, you could be getting your chemotherapy, and you could be really suffering the side effects of the chemo and really suffering from the emotional weight of how this new diagnosis is changing your life. So even when you're getting therapy, you can also be seen by the palliative care team. Whereas on hospice, that's usually a time when we are retreating from things like chemotherapy that are disease-focused. And instead of doing that, we are bringing the full force of our team to giving people the best quality of life, no matter how long that might be for, but generally less than 6 months. True end-of-life care, I think of as providing symptom relief and emotional support for families and patients really in the last hours to days of life. So the three are related. They're all palliative in that we are attending to the many dimensions of suffering in each instance, but they are still very distinct in terms of the timing that the services can be available and what services you can receive alongside each one.
So palliative care can come in at any point, as you just said. As a practical matter, when do the palliative care people show up? I know a lot of the stories in your book are people who have, are pretty close to the end of their lives. And even in the title of your book you talk about the 11th hour. And even people I know in my own life, people are suffering long before palliative care tends to show up. So when do you get involved in, and how is that kind of thing shifting?
So another great question, because I think technically we can be involved at any stage of a disease, but unfortunately my experience has been that palliative care is called towards the very end of life in general. And that's been my experience at the places that I've trained as well as where I currently practice. And I think part of the reason for that is that palliative care is so misunderstood in the medical and the general community. I know some of my physician colleagues feel that calling palliative care means giving up. I think some patients and families also feel that way. So we're sort of set up as a binary that either we're doing everything and going for cure with someone's regular doctor, or we're doing nothing and calling palliative care. And of course, that's not the truth, but it is a perception that I have to contend with pretty frequently. I think part of the reason for it is that many of us were not really exposed to palliative care and what we really do on the service when we were in our medical or nursing training. And so that lack of familiarity with what a palliative care visit looks like, what a palliative care team looks like, I think that unknown aspect of our work and our field makes people less likely to call us early on, when we could be very useful in keeping people's quality of life the best possible throughout their journey with the disease.
You tell a story about one of the early patients that you worked with as an intern, and this was somebody with advanced cancer, and he had a fungal infection, and I think he was in the ICU, and he had a fungal infection in his brain, and medications were at some points kind of stabilizing the situation a little, but he was not going to recover from this infection. And you sat down and bumbled your way through a conversation with him and his wife and maybe kids about the fact that this infection was not going to go away, and what were the goals, what were the wishes, really that kind of conversation that you wrote, that you read the excerpt on, but your new doctor kind of attempt at it. And afterwards, the wife said, basically, thank you, can we not talk about this again? How often do you encounter that kind of reaction from families, and how do you deal with that?
I think, so I will never forget that patient. I stayed in touch with his family for many years after that, so he defied my odds and really survived for a long time. But the kind of response from families of not wanting to talk about it is both very human, but also presents great difficulties for not only them, but the physician team and the nursing team caring for a patient. I certainly encounter it. And I think what helps me to get around it, or to I think of it as a softening of the resistance that I'm often met with. I think softening comes with helping people to understand that this conversation is a part of doing everything for a patient. Some of the families and patients that are most resistant to these discussions are the ones who say, well, I want everything done, I'm not giving up. And I've found a lot of success in helping people to understand that doing everything means also talking about the best case scenario and a harder scenario, and helping them to anticipate both. And when we take it back to just planning for a hard scenario, it can sometimes diffuse all of the emotion around the specifics of a patient's scenario. It's not always successful, and I think something that I have learned is, just like, for example, a surgeon cannot fix every patient that he or she sees, I've also had to learn I will not be able to connect with absolutely everyone. And sometimes, despite my very best efforts to achieve that softening of the resistance, I may not be able to get through to every family. So what does it mean to walk alongside them, even when they don't want to talk about what's very obvious to the rest of us? Maybe it just means continuing to show up, make sure the patient is comfortable and not suffering, make sure that the right resources are being offered to the family, and being there at the time where a crisis may arise, and then we need to talk about it.
So one of the things that I found most fascinating were not just your difficult conversations with families, but your difficult conversations with physicians and oncologists and surgeons. And there's one encounter that you described with I think it was an oncologist who basically said, well, yeah, you can come in, but just talk about pain. I don't want you talking about hospice. I don't want you to talk about end of life. Just talk about the pain. Talk a little bit about how you deal with the fact that you are working in a medical center that is really based on a whole model of treatment at all costs, survival, aggressive care.
Yep. I have actually found both the most frustration and the most meaning in trying to get through to some of my colleagues who are very resistant to palliative care. And my approach, like with that oncologist, has always been that I need to meet the doctors where they are in their understanding of palliative care. It's kind of just like I treat my patients and their families that way. We almost have to treat our colleagues and their discomfort with this topic, with the reality of their patient's mortality. Sometimes by throwing compassion and understanding at them. And so it's not to say that it's not upsetting. I think the encounter I talked about in my book, the oncologist had spoken to me pretty rudely in front of a medical student, which was extra awkward because the medical student is watching this interaction and the tension between what he knows I actually do on the service and what the oncologist's presumptions are. So there were many layers to that particular incident, and I really feel like I had to model the highest level of professionalism in that interaction. And generally, that is, I think, the only way to be successful, because to alienate any of my colleagues means that their patients in the future may not be referred to palliative care. So it's a very delicate dance between dealing with my own frustrations separately and finding ways to take care of the emotions that come up when there's a really blatant misunderstanding of what my team does, but then also putting that aside and just thinking about what's best for the patient and where I can meet my colleague wherever he or she is in their understanding of palliative care. I will often, especially for patients in the hospital, when I do family meetings, I often ask that my colleagues from surgery or oncology or any other specialty join the meeting so that they can see firsthand what we do. And actually, a very low percentage of the patients we see at Keck and Norris, on the data we keep, very few of them are actually referred to hospice. So helping them to see through numbers and through direct patient contact that our objective is not to put everyone on hospice. Our objective is just to name and be with and address the suffering of everyone in a room in the family meeting. And that sometimes includes my colleagues who may have very emotional attachments to patients, and trying to help them contend with that when a patient's clearly dying. Actually, those have been some of the most meaningful and challenging parts of my practice.
And how routinely do your colleagues accept those invitations to those meetings?
Well, there's some teams that I say I won't do a meeting unless you're there. And, some of the meetings that I'm doing today, I had to get in touch with the attending physicians from, one was the surgery team, one was a neurology team, and say, hey, I'd really love you to be at this meeting. I think it helps not only for them to see what meetings are like, but also if they have been the primary doctor caring for a patient, I think it's very important for the patient and family to feel like no matter what someone is going through, their treating physician is going to show up. I think them being there is not only educational, it's also really symbolic that we're not abandoning this patient and handing them over to a new team that hasn't seen them through the whole hospital stay.
So you worked at a couple of different medical centers, hospitals in
Yeah.
Los Angeles, and in your previous job in Los Angeles, you were doing home visits, which you write about, and working in low-income communities of color. Can you talk a little bit about the cultural aspects, the racial barriers, and really the cultural issues around healing and health and death that come into play in palliative care?
Certainly. I think that's a topic that I could wax on about for days, so I'll try to keep it concise. But when I was doing home hospice, I covered South Los Angeles. I would see patients in the hospital for the first half of the day, and then I was assigned to go see patients in zip codes that were all in South LA. And nothing in my training had prepared me for taking care of really vulnerable patients in this area. These were patients who lived an average of 10 years less than patients in wealthier coastal areas in Los Angeles. These were patients who had faced tremendous inequality in healthcare access and in every other part of their life. And I was showing up really towards the end of their lives, trying to give them dignity and comfort. And what I found was that hospice services were often not enough for them. Many of them had children who worked multiple jobs to stay afloat. And in hospice, though we can do a lot, we cannot give you a caregiver, for example. We cannot fix very deep-seated, difficult family dynamics. And we certainly can't, in the dying process, erase all of the inequalities in life that become inequalities in dying. And so much of what I encountered was how socioeconomic disparities impact end-of-life care. One thing I saw commonly was that this idea of the proverbial good death that many of us think about simply wasn't the imagining of a good death in some of the homes where I went. And to be specific, you know, many of us think we want to die surrounded by loved ones in our own home, but sometimes home was in a dangerous neighborhood. Sometimes if home was in a neighborhood like that, pharmacies did not stock opiates and you couldn't get your pain meds easily. Sometimes if your neighbors or someone else knew you had a hospice doctor visiting, you became a target for break-ins. And often patients felt, I'd rather die in the hospital, where people are professional and know how to take care of me, my kids work many jobs, or I don't have any family, and who's going to come help me with my pain? If I'm in the hospital dying, the doctors and nurses will take care of me as they always have throughout my journey with cancer or heart failure. So that was one very surprising thing I came across. I also saw that some families really felt that dying at home would mean their families would live in a home with a ghost. And they didn't want to die at home for that reason. And yet I had really no other resources to offer because we don't have standalone hospice facilities. And you have to meet very specific criteria to get hospice in the hospital or in a nursing home. And so that was another thing I came across. And lastly, I really think that a lot of people, when we talk about end-of-life care, we're using some words and language that work very well in English, but don't always work in other languages. So thinking, even in my own native language, Hindi and Punjabi, you know, I couldn't have the sort of conversations in English in Hindi. The concepts don't translate easily. And so that was another, the linguistic barrier, I think ended up being a cultural barrier when taking care of some of my patients in those areas. And so it's a really complex, rich topic. I found that sometimes mistrust of the medical system would make it so that patients did not want hospice or felt that hospice was just giving up on someone. But I encountered that less often than I did what patients maybe wanting hospice and comfort care, but not having the setup at home due to socioeconomic disparities to be able to really achieve that.
Yeah, I thought that was a really important point. And I wrote a book about hospice and found that even families with the resources, it's no small thing to deal with this at home. And for some people, it works out really well. But for some people, it's just huge. And your point about there really aren't options for people who want that kind of experience, but don't either want to or have the means to do it in their homes is a real gap in the service. I want to ask you one more question. I think we're going to open it up soon for participant questions, and I have a million questions for you, so I'm going to...
We can continue it offline.
How has the opioid crisis impacted your practice, willingness to use painkillers, adequate painkillers, opioid painkillers? Can you talk a little bit about that, please?
Sure. I have certainly seen that the opiate crisis has made prescribing medications that cancer patients in particular really need, made it much more difficult. A couple of recent things that have changed. Number one, if I prescribe for a cancer patient over a certain amount of morphine equivalents per day, I also by law have to prescribe them the opiate reversal agent, Narcan. And I can completely understand the reasoning behind it, especially in light of our opiate crisis. But I think it puts patients and families in a very difficult position, especially if they're late stage suffering from cancer. Is there, for example, loss of consciousness? Is it due to the opiates or is it due to the dying process? And asking families to make that determination and administer the medicine, I think it places a real burden on them. And when someone gets the opiate reversal agent, it's very unpleasant. It's very painful. It reverses the effects of the pain medicines throughout the body, so it can be really uncomfortable. So that's one thing that's changed. I've also seen that patients who have certain insurances, we have to jump through a lot of hoops to get opiates and changes in opiates and increased doses of opiates approved by insurance. And that's been something that, we as a palliative care group have always been very careful about. But now I'll sometimes have to get on the phone and really justify why somebody with end-stage cancer needs a high-dose fentanyl patch. I didn't necessarily have to do that a few years ago to the same extent. And lastly, I think that pharmacies are less likely to stock as many opiates. This has always been a problem in some communities, but I think it has been exacerbated by the opiate crisis. So if my patients come to see me, like a patient I just saw yesterday who lives at a distance, I will almost always ask them to pick up their prescriptions from our pharmacy at USC because I know we have everything in stock. And I think the not knowing is very anxiety provoking for a lot of patients, and even for me. I can write for the meds someone needs, but if they can't get it because of new regulations, I think that can be, it's something that has backfired in the community of patients who are really suffering from end-stage disease.
Mm. Well, as I was reading your book, I got so many story ideas, so I'm going to add this one to it. There's stories about variations in palliative care, going from one hospital to another to another. Palliative care look very different. Doctor training, some of the cultural aspects that you talked about. I'd like to ask you, for my journalist friends who are tuned in, what stories would you like to see written?
Oh, you're asking me?
Yeah.
Okay, so I thought when you said journalist friends, you were opening it up. So, I think that journalists have tremendous power in our country to tell stories that go against the grain and that can inspire conversations that we wouldn't otherwise be having. And I think sometimes just covering people who have had good experiences with palliative care, even though they were skeptical at the beginning, noting for others the change in attitude, what helped people to be more open to palliative care, what were the doubts they had, following somebody from the time of diagnosis to the time of death, I think could be a really interesting sort of tale to tell, especially with regards to how their openness to palliative care and hospice may have changed. I think in general, we really like to focus on the medical miracles and on the exceptions to the rule. And those exceptions to the rule are really important to know about, but they come up in my family meetings fairly frequently. And I find myself being in the position of explaining why a certain story that ran in the news doesn't apply to a particular patient situation. And I wonder if we took the focus away from the medical miracles, not entirely because they're important, but we balanced it with some of the more commonplace things that tend to happen to people facing a serious illness, we might balance the narrative and the conversation a bit more so that a patient in a meeting may say to me, oh, I know what you're talking about. I read a piece in the LA Times where a reporter explained or went with a patient along their journey at the end stages of cancer. The reporter wrote about palliative care. So I have heard of that, and I saw, how that particular patient made his own decisions. So I think it's more of a balancing of the narrative that might be really transformative, because I can't tell you how many patients of mine read the news, watch medical dramas even, and come in to a conversation with me with their mindset informed by what's out in the media.
Well, news is the exception often. That's what we,
yeah.
It's the man bites dog situation. And,
exactly.
I know from my days as a daily journalist, I used to do story after story after story every day, looking for the best story, looking for the best feature
Yep.
for Monday, and really not thinking how the coverage shapes a kind of a cultural narrative about medicine, about death.
Yep.
And I think you're describing, thinking about that narrative very differently, and
Yep.
probably shape that narrative differently.
So I'm going to jump in for a moment and just we're going to open it up to our audience here, but I want to thank both of you for this wonderful conversation. I wanted to start out with a question of my own for Dr. Puri, which is really this moment of end of life is probably one of the more intimate and difficult moments where you as a reporter could really be seen as barging in or an interloper. Do you have any suggestions, both just how to handle that and also even the vocabulary of how you talk about it? We've talked a lot about words, but do you wait for someone to say they're dying? Do you ask that question when you know they're dying? I mean, what would you recommend?
That's a great question. And I think, not having been in a reporter role, I can give suggestions kind of knowing that I don't know what I don't know, so to say. But I think when you're introduced to a patient or you find someone to interview and follow on their journey, I would suggest thinking about what language they're using and trying to mirror that and asking them, what are they comfortable discussing and what's off limits? And I think a lot of people respond really favorably to that. And I ask sometimes the same questions in a palliative care consult. Are there things that are off limits? How would you describe the state of your health right now? What's your understanding of what's going on for you medically? Because what they will tell you is a great insight into their mindset, and how they tell you, the words they use, I think are very instructive to reflect back and use the same vocabulary. And sometimes I think asking permission to use scary words can be helpful. And saying something like, if it's an appropriate moment, saying, would it be okay if I used the word dying with you? And people will always be honest for the most part about what they're comfortable and not comfortable saying in terms of language. So those are some of my suggestions.
And Fran, I wanted to ask you about this because you have been a journalist for your entire career and you co-author this book, Changing the Way We Die. Did you have any awkward moments where you felt you stubbed your toe with this kind of thing?
Well, I came into it through hospice. So the patients I met were already were on hospice service. So somebody else had that conversation with me before I came along. And, you know, and even at that, people will talk about it differently. People are, people are different about how much they want to share. I mean, that's true about anything. So it helps to take their cues. Sometimes family members are more resistant or less resistant. Sometimes family members don't agree on what's going on and don't even agree on the set of facts. So there's that becomes very complicated. You know, as a journalist, you don't want to be adjudicating fights, but you know, people have completely different sense of what the situation is. So, but I was not in a situation where I had to broach a topic that had not already been broached by the family and by the medical team. But I, you know, I also was pretty blown away by how open people were to having me walk into their homes with their doctors, with their nurse, with the social worker, without that person. And also the entire time we were reading the book, you know, it became with my co-author, Sheila Himmel, it was kind of a joke that, you know, we would kill any dinner party conversation when people said, what are you reading on? Like, isn't it depressing? And I was also really blown away by how not depressing it was. And that's something that you also write about in the book, that I feel forever changed as a person, as a daughter, as a mom, by my experience doing that book. And certainly there was a lot of sadness, but there was also a lot of just human power, and it was not a depressing experience at all.
Yeah.
And I don't think the book was depressing. Your book certainly is not depressing.
Thank you. I didn't want it to be depressing because I think, you know, I think you're absolutely right, Fran, that people's gut instinct is to say, I don't want to read a book about death or dying patients. But I think if death is a part of life, then these sorts of stories and these sorts of books are ultimately about life and about living, because the dying are still with us. They're still living. And I think to deny them that would be to write a depressing book. But to move into that space and to say, I see you, you still have a story, you still have a life, I'd like to learn about it, it's a much more empowering stance to come to a patient on hospice or in palliative care with.
Yeah.
And we have two similar questions, one from Dr. Jean Dorio and another from Blake Farmer. So Dr. Dorio says, palliative care is not paid for by Medicare outside of the hospital or SNFs. I'm not sure what that stands for, but I'm sure you know. Hospice care is. Therefore, isn't there a tendency to financially move patients from palliative into hospice care? And can certain hospitals and HMOs take advantage of this, wiping their hands of their financial obligations? And then I'll just share Blake's question because it's so similar. He says, I'm curious what Dr. Puri has to say about how palliative is paid for. It usually seems to be a roundabout reimbursement scheme, and have you run into problems making a business case within the hospital?
Yeah, so the finances of palliative care is definitely something worth talking about. I think it works slightly differently in every institution on the inpatient side when patients are hospitalized. But to speak to what happens outside the hospital, there are far fewer palliative care clinics and far fewer home-based palliative care teams that can come to patients' homes or to skilled nursing facilities, which is the SNF. So the first person was absolutely right that the finances are very different. And sometimes it's true that some health systems see that it would be cheaper for them to put patients on hospice. And it's a sad reality. My hope, at least here in Los Angeles, we do have agencies that provide pro bono home-based palliative care or palliative care in a nursing home. And that is basically part of their pro bono work for patients who are kind of in that bridge period between active treatment and going on hospice care. I think reimbursement schemes for palliative care are changing because there's so many wonderful benefits of palliative care for patients and families that we're now seeing in medical studies. And unfortunately, I think the financial benefits are also there, and that's what I've seen it takes to change systems. I will always maintain that we should have palliative care available to everyone and reimbursed for everyone because it's simply the right thing to do. But I do think when a good palliative care team goes in, helps the patient understand the true medical situation they're in, and talks with them in a skilled manner about what they want for themselves, that may be the first time that someone really might be empowered to say, I may not want to go through a certain set of treatments anymore. But the cost savings of not doing those treatments is not the point of palliative care, and I cannot emphasize that more strongly. The point of palliative care is to really help people figure out what they want for themselves in the time that they have. Sometimes that's continuing active, expensive treatment, and sometimes that's saying, if that treatment means I stay away from my family and my home, it's not what I want. So that may be a long-winded way of saying there are changes to reimbursement happening. Currently, there's a lot of pro bono outpatient palliative care work, and my hope is that in the future, all insurance companies are going to offer payment for palliative care right alongside active treatment, simply because it is hands down the right thing to do.
We have a question from Christian Sider, who says, when having conversations with patients about transitioning from curative to comfort care measures, what are your thoughts on actually using the words death, dying, etc., versus euphemisms such as passing away or transitioning?
So I will tell you that as in my training, I used a lot of euphemisms. And I used euphemisms because in retrospect, I thought that saying death and dying would scare people. I now use those words fairly frequently because I think that patients, in the midst of a conversation that is going well, you want to prepare them for the use of those words. But the use of those words is being compassionately honest in a way that I think we're sometimes afraid to in medicine and nursing, and even in our own lives. So I understand why people use words like passing on, but I've made a choice not to use them. Just like I don't call palliative care supportive care, I call it what it is, and I explain what that means. And if someone says to me, I really don't want to talk about the word, I don't want to use the words death and dying, then I ask them what scares them about those words, help me understand, and then I ask them what vocabulary they would prefer. But I really do think talking about what is actually one of the paths to freedom and to really open, vulnerable, intimate conversations with patients and families about what they really know and about what they really want.
Thank you. We have a question. Where'd it go? It's vanished from my screen here, but it was from somebody writing from Pune, India. And here we go. Reena Mukherjee, who says, how do you deal with patients who are extremely ill-tempered and irritable and emotional support? Their families may be stressed too and feel overburdened with such a relative to handle in spite of being understanding and supportive.
So the last part of that question kind of cut out for me. Can you read the last part again?
Sure. Reena writes, how do you deal with patients who are extremely ill-tempered and irritable and need both physical and emotional support? Their families may be stressed too and feel overburdened with such a relative to handle in spite of being understanding and supportive.
So I think this is a situation we certainly run into. I would say not even just with patients who are dying, but I've seen this in all situations in medicine. And I think that sometimes it's about two things. One, having compassion for yourself as the doctor and as the relative, that this person is going through their own process and there may be things I can help them with, but there may be things I cannot help them with. And drawing boundaries with patients like that, I think, is very important. I think trying as much as possible to understand where the anger is coming from and the irritability is really important. It might be a coping strategy that this person has used all their life. And trying to help them to cope differently is a monumental task, I have found, but it's not impossible. It's not always the responsibility of the family to help them with that, though. So when I see patients who are like that, I try my very best to find a way in. I try my best to get them to soften and help me understand where the irritation is coming from. But I also really draw upon skilled colleagues in social work and psychology and nursing and psychiatry sometimes to help me with a team approach, get into their world and understand how best to help them and understand what their irritability really represents, because it often represents grief and depression or other things that we can, as a team, address. And I think with families really trying hard to understand that sometimes someone is going to act as they're going to act no matter what you do. And you must find a way to find compassion for yourself and care for yourself when you are facing the stress of dealing with a relative like that, and asking for help, because we have resources in hospitals. We have social workers, therapists, we have chaplains and spiritual support in addition to the physicians who are helping the patient medically. And all of these other providers are instrumental in treating families and patients.
Thank you. And Dr. Puri, I wanted to ask you something you touched upon when we spoke earlier, which is just the kind of complexity of trying to be understanding and sensitive to cultural values, but not making assumptions either about how somebody might want their care to be carried out. Maybe you could speak to that.
Certainly. So I think when I'm seeing a patient for the first time, no matter what their background, my approach is always to say the patient and the family are going to tell me where they are, both in the understanding of their disease and also in how their culture, spirituality, and language, and even other factors inform their lens on the situation. So I almost go in as an anthropologist with no assumptions. I've usually read their medical history, but I go in knowing that I don't know anything really about this human being. I know a lot about their diseases, but I don't know anything about them or what it's meant for them to live and now possibly be dying with the disease. So I think part of what it means to be culturally humble is to ask patients to share their lens on the world and on their disease with you. And that means listening a lot. So a lot of times in medicine, we physicians love to talk at people. And one of the most transformative parts of my palliative care training was really learning how to sit in silence and listen. Because when we listen to people, that's part of what it means to be humble, to put them in the driver's seat and to say, you know, I may know a lot about medicine, but I don't know about your life. I don't know how it has been scarred or changed by this disease. I don't know how your culture might inform it, and I hope you will share it with me, because to be a good doctor to you means me understanding all of these facets of your life and how they've come to bear on your dying.
Well, you started with reading that beautiful excerpt about an experience that you had early in your training, and really something that shaped you and professionally. Now you are at an academic medical center and you train physicians, both people who might get the bug, as you did, to go to care, and people who are going to go on to all kinds of specialties. So how do you train physicians in their medical training, and what would you like to see all of those students who come through take into their practices, even if they don't practice palliative medicine?
So I train students in a couple of different ways. One, I do lectures in the medical school about things like how do you communicate bad news? But the most learning, I think, takes place when they rotate on my service in the hospital. So in the fourth year, the last meeting, people can sign up to rotate on our service at CAC Hospital and the Norris Cancer Center, and they spend either 2 weeks or 4 weeks with us. And what I do is I teach them things like basic pain control, nausea control, things that we actually don't get dedicated ongoing teaching on in medical school, shockingly enough. And so I help them with their symptom management. And then I also take them to all of the meetings that we do. If they feel ready, I ask them to go ahead and lead a meeting, just like my mentor in my fourth year did. And I really try to make the rotation one that I hope their wheels turn in the fourth year, just like my wheels turned in the fourth year, as I wrote about in the book. I think it is through seeing over and over again what we do in palliative care that makes them better physicians, because they really know what we do and what we don't do. They generally take away when to call us, which is really important. They take away new knowledge about the difference between hospice and palliative care. And they learn how to introduce conversations that can be really, really hard to introduce because it hasn't been a consistent part of their training. I definitely don't think that people leave the rotation as experts, right? Because I don't even know that I am a full expert. It's kind of a lifelong process of learning this art and science of any field of medicine. But I do think they take away a much deeper appreciation for their role as physicians needing to include caring for patients at this stage in life. It's not just something to pass off to a palliative care team. It's also something that they can really own. And I tell them often that people are going to remember you being there at their darkest hour, and they will remember the words you use. So let's talk about what words to choose and how to recognize when you need expert help in these situations. And that's another thing I really do think they do take away.
Thank you.
Thank you.
I want to thank our two wonderful speakers for this really informative and insightful conversation, and to thank all of our participants. We will be sending you a survey shortly, and we welcome your feedback on this webinar and on future topics of interest. And we will be archiving this webinar at centerforhealthjournalism.org. Thank you so much.
Thank you.